Good afternoon, everyone. My apology, this talk actually was supposed to be in the morning session, but there was a technical problem, which we just rescheduled it for the session. I modified it because of the time. I was given more time, and I'll focus on the congenital aspect of the talk. I have to say, great presentation, Dr. Khadija. Really, thank you very much. So, Dr. Khadija presentation of cardiovascular risk and diabetes in women. Think of that. Think of Dr. Marta and Dr. Omar Falasi, arrhythmias in women. Recall the heart failure and the next heart failure session. All of those risk factors are something that we identify with patients with pre-existing congenital heart disease. So this is just an additional layer of complexity that we deal with in patients with congenital heart disease. I look after patients with congenital heart disease with inheritable heart condition, and when they decide to go for pregnancy, as you were aware today from our discussion. This is a 2005 article or editorial by Dr. Carol Warrens, and there is a discussion, are patients with, who survive into adulthood, adult with congenital heart disease, are they born to be bad? And I will leave that to your judgment at the end. I'll start with a case. This is 27 years old, female, history of tetralogy fellow who had a cardiac surgery around the age of 2 years old, referred for a pre-employment. She actually has lost follow-up for more than 15 years. She has not seen anyone after the age of 12 since she was last seen by her pediatric cardiologist. Case 2, 18 years old, female, on a wheelchair with unrepaired cyanotic heart disease, was diagnosed with patent ductus arteriosus, has progressed into pulmonary hypertension, then Eisenmenger, which is, she's not a surgical candidate at this point of time. It was actually the family decision not to proceed with surgery, despite the availability of congenital cardiac surgeon at that time. Case 3, 57 years old, female, mother of 5 children. She presented with shortness of breath and complaining of chest pain, exertional chest pain. There was an incidental finding of mild to moderate pulmonary stenosis, and she was referred to my clinic to evaluate her for pulmonary valve replacement or pulmonary valve intervention in order to help her with her symptoms. When we look at gender and adult congenital heart disease or congenital heart disease in general, do we think that there is differences in prevalence, in outcome, surgical outcome, especially with the adult cohort? This is data from one of the largest registry in Europe, the Concord, and I will refer to the findings of that registry. So they looked into more than 7,000 patients. All outcomes were before the entry into the registry and during the subsequent follow-up. They focus on differences between men and women. They were analyzed, and underlying congenital heart disease was taken in consideration. The mean age was 35 years old, and around 50% were female. What did they find? There was no gender difference in mortality, but we just attended the presentation for pulmonary hypertension by Dr. Hani Sabur. Those patients, actually, the women had a significantly higher risk of pulmonary hypertension. There was a lower risk of aortic outcomes, there was a lower risk of endocarditis, and they had lower risk for ICD implantation. And also the risk of arrhythmias appeared to be lower in women. This is just the distribution of the congenital heart conditions. If we look into gender distribution of congenital hearts, there is more prevalence of right-sided lesions, RVOT, RV outflow lesions, Ebstein's in women, and more of left-sided lesions, aortic valve, aortic arch lesions in men. Gender differences in a prognosis have been always reported in cardiovascular disease, but less studies in congenital heart. As I said, there is the pulmonary hypertension, which is a major cardiac outcome. And the whole outcome of a survivor of congenital heart disease will change if they develop pulmonary hypertension. And that varied according to gender. Is there any gender differences in prevalence and surgical results? As I mentioned, there is a mild, but really not that much significant prevalence of congenital heart disease in females. The complex, males tend to have more complex diseases, but if a female has a complex disease, usually the outcome is worse because usually it's associated with lower weight at birth, prevalence of extracardiac anomalies, and genetic syndromes. Why do we care about congenital heart disease in women? Why should we think again and again when a woman present to the clinic with the first referral? Because the hemodynamic and the physiologic and hormonal changes of women throughout their life cycle has an effect on the hemodynamic sequelae of their congenital heart. More complication may be unmasked during certain time of their life cycle, and we will go throughout. So what about adolescent? Congenital heart disease patients who are transitioning, regardless what's the transition age. I think here is 14 or 12, in Northern Emirates 12, in Abu Dhabi 16. Regardless of what age, they need a very clear transition plan, regardless of the gender, regardless, females or males. There should be a very purposeful planned movement of adolescent with chronic medical conditions from a child-centered care to adult-oriented health care. Last week, I was surprised to find 17 years old, single ventricle, female, who looked like 7 years old, suddenly in the clinic, no process of transition. She was palliated with Fontan. She has systolic dysfunction and heart failure. Her clinical course was complicated with one of the most complicated outcomes in single ventricles, which is protein-losing enteropathy, which is associated with much higher mortality. That patient was in the office with no prior transition or preparation not from the patient side, nor from the receiving physician. For female patients, and if this is, I have a more lenient policy with the female patients. I actually accept them from 12. The reason is I try to cover that transition because I have found through studies of the UAE congenital heart disease database that we lose them from the age of 13 to 17. Females, that's the age of the puberty and the hormonal changes, so they tend not to go to their to the male pediatric cardiologist. So this is an additional opportunity of loss of follow-up. So we may rethink, maybe should rethink when to start transition for female patients. There is no, I can assure you, there is no clear transition CHD care plans that I have come across. We are trying, but we are not there yet. So what happens in young adulthood and during pregnancy and postpartum? This is the reproductive part of their cycle. And it's important. And we hope that we see the patients before they get pregnant and before they plan their families. Young women, this is the first cartoon, they need established specialized adult congenital heart disease clinical care. Studies has demonstrated that being referred to an ACHD clinic or care actually affects positively the mortality of the patient. So they live longer, if they are referred and they are under ACHD care. They need comprehensive review of their significant hemodynamic lesion, if there is any. They need to be timely referred to surgical and interventional treatment if needed. They need excellent dental care. I added that because I just come across a 21 years old, newly graduate, truncus arteriosus, who is struggling with a fever for the last 2 weeks. I think she has seen multiple physicians, needed to be admitted under internal medicine. And I think after 2-3 weeks of admission, they remember, oh, oops, she has a congenital heart disease. Maybe we need to consult her ACHD cardiologist or any cardiologist. They need preconception care. No matter when I see them, I try to do that preconception counseling as early as possible. At the age of 12, at the age of 14, at the age of 16, because there is a very high chance that you may not see that patient again. During the reproductive part of their life cycle, pregnancy carries risk of cardiovascular complication, arrhythmias, heart failure, cardioembolic strokes. Rarely death, I haven't seen any. The risk stratification data did not really show death except in extremely sick patients who were involved, but they need definitely follow-up. The hemodynamic and hormonal changes of pregnancy can destabilize the cardiovascular, and I can show you why. There is a significant, there are physiologic changes of pregnancy. I believe Dr. Dima yesterday has described that as a stress test and a window to the future of the patient. And that's that's an excellent description. There is an increase in the blood volume of about 50%, which peaks in the 3rd trimester. There is increase in the plasma volume. There is increase in heart rate. There is a physiologic anemia. So all these changes start from the 1st trimester, 2nd trimester. They peak between in the 3rd trimester, and many of those changes actually persist for some time after delivery and early postpartum. The first, you need to closely follow up your patient in the first 4 to 6 weeks after delivery. Patients will need at least 6 months to go back to their baseline before planning any comprehensive cardiac workup, including a diagnostic workup to decide about surgery or intervention. I usually, if the patient is stable, I do not plan any cardiac MRI, cardiac CT, or comprehensive echo till 6 months. I do some of the echo follow-up if there is any concern about effusions, gradient, or systolic function, but the comprehensive assessment, I don't do them till 6 months at least. And this is just to go back to pre-pregnancy baseline. One of the most challenging complication in congenital heart disease during pregnancy, and it's a very bad prognostic for females who are planning for a pregnancy in the preconception, is a heart failure. Either because of systolic dysfunction, because of mechanical obstruction, either left-sided or right-sided, and that's actually complicate the clinical course. It affects both maternal and fetal outcome. There is a risk of fetal loss, prematurity, and other issues related. I have to mention also, when you are counseling those patients for pregnancy, include the recurrence rate. I quote 1% in the general population, 5 to 7% in women or men who are planning to have children. That percentage goes up to 50% if, let's say, our tetralogy of Fallot patient has any genetic association like DiGeorge syndrome. There are small studies which show that there is a negative impact of pregnancy on systemic right ventricle. So patient with atrial switch or with a Fontan with RV morphology systemic ventricle. They have long-standing and long-term sequelae of pregnancy on their ventricles. This is a pregnancy outcome in our adult congenital heart disease patients in Corniche. As it was mentioned earlier, there is about 670 total patients, around 90 patients with congenital heart, non-rheumatic valve lesions, and we were following up, and we come across during our cardio-obstetric clinic. We presented their data at the International Congress on Cardiac Problems in Pregnancy, which I'm reminding everyone will be held in Abu Dhabi this October. We had various outcomes. Our most challenging cases were the single ventricle Fontan patient. We had about 5 patients during that study. In that database, we struggled with patients with unrepaired congenital heart who are cyanotic. We struggled with patients, or we were challenged with patients with systemic ventricle dysfunction. What about older age? No gender-specific data in older ACHD patients. There are recent published papers about surviving into beyond youth and beyond middle age, but we don't have gender-specific data about the outcomes in females. Back to the cases. Case 1, the 27 years old who lost follow-up. She's a tetralogy of fellow who lost follow-up for almost 15 years. Her clinical assessment and cardiac imaging showed that she has severe pulmonary regurgitation, severely dilated right ventricle with an end diastolic volume more than 178. Usually the cutoff to intervene is 160 to 170. She actually had an impaired exercise test and some burden of arrhythmia. She was referred. She had her pulmonary valve replaced, and she had a pregnancy following the pulmonary valve replacement. She's actually still pregnant. I'm still following her up. That's 18 years old. Very challenging case. Now the family is demanding evaluation for a transplant. We had multiple MDTs, multiple family meetings, very challenging. Multiple family members are involved in the patient care without consistency and without adherence to medication or clinical follow-up. The 57 years old actually fits what we've been discussing yesterday and today. She's a female. She had multiple risk factor for coronary artery disease. So when I put her in a treadmill, she had a very positive stress test. She was taken to the cath lab, and she had an LAD lesion, which required a PCI. My interventional cardiologist thought that I take a very good history. So what I learned from looking into gender, into ACHD, both the improvement in the surgical medical therapy, especially now with the heart failure evolving, and the long-term scope is changing. The gender-specific outcomes is really very interesting, and it's worth more studying. And I think our communities and our patients in the Gulf area and the Middle East area will have very interesting findings, given how unique our healthcare system, the community structure, and the profile of our patients. The congenital heart disease, very heterogeneous and has some individual presentation, which sometimes could be difficult to elicit all those differences. The take-home messages that I want you to take with you, that congenital heart disease is common. Keep this figure in your mind. It's 1 in 100. Women exhibit hemodynamic changes throughout life, so maybe we should really rethink the gender differences, and more data and research in gender differences, especially access to care, timing of access to care, transition and outcomes are all needed. Thank you very much.